All right, first things first, good morning, everyone. Welcome to today's Comprehensive Tactical Athlete System Leadership Education Clinic. Today, we are going to be discussing acute injuries, right, with regards primarily to musculoskeletal injuries, because this is the particular realm that, without being licensed or having some type of medical degree, that we should be, as leaders, cognizant of, at least cognizant or aware enough about anatomy to be able to address, both for ourselves and our soldiers. Musculoskeletal injuries are a normal part of life. They're a normal part of training. And within our particular occupation, they're extremely prevalent. So it is difficult being a leader that has been in for 10, 15, 20 years and seeing a soldier who is experiencing some type of, let's say, acute pain in their foot, in their ankle, in their leg while running, and then have no idea how to be able to assist them. Meanwhile, we can look at a form, right, that they have to be able to create a memo or something and say, this is exactly the font that it needs to be, this is a placement it needs to be, and we can fix a lot of these other pieces, but we rarely have answers to a critical aspect of their well-being, which is their body. So that's what we're going to be talking about today. This clinic falls under the pillar of human performance optimization and injury prevention. I know it's a mouthful, HPOIP. The reason I actually labeled our reconditioning program as such is due to historical aspects. So HPOIP is actually a legacy class that used to be covered within the First Sergeant and Commander's course, or the Captain's Career course, rather, to discuss how commanders need to look at the medical aspect for their soldiers and what they can do from that point. So I'm taking it from a legacy name, and I'm trying to modify that under our scope of what we can do here as leaders, both as NCOs and commissioned officers. But to kind of move forward with this, I have a quote here on the screen, and I want you to read it internally, kind of digest it for a second. I'll give you some time to do so. All right, and this, again, questions for everyone. Feel free to just unmute your mic or to speak up if you have input. But I want to know, what are the current practices in your unit when a soldier feels that they are injured, or whether or not they have a profile, they feel that they're suffering from some type of pain or discomfort physically? What are the normal conversations and practices that you've observed in your current unit?
Pretty much non-existent. They're not non-existent. Really, it's you have to be careful with these, because usually, often soldiers try to get away from like PT hours and whatnot. They may be injured, but maybe they just want to get away. So you have to actually ask the right questions, like, are you really in pain, or it's just like soreness? It's like, I mean, same thing when I was in the trail, like as drill sergeant, you have to evaluate each soldier different. Like if this soldier is just weak, probably, are you really injured, or you just sore from PT last week or whatever? It's something. It's kind of like a gray area we have to be careful with, I would say.
Oh, I absolutely agree. So, there's a lot of aspects that were just brought up. A lot of variables that are already brought up, right? The soldier's perception of pain versus discomfort,
right?
Our perception as leaders for that soldier's experience with pain and discomfort, which is extremely challenging. So we'll get into that.
The culture in the Army is also like, okay, probably just suck it up and drive on, which is not always the case.
The potentially quote unquote old school aspect of grit and perseverance being fundamental variables for us in uniform, right? Because we are tactical, right? Everything has to be, combat related and hua. Absolutely, absolutely. What about anyone else in the room? What do you think about the question posed earlier?
I just feel like as the soldiers have these injuries, like the other sergeant was saying, and evaluating each soldier definitely off of their needs basis, what you've observed over the years, and just general soldierism. That's kind of all I have.
All right, good, good. It's a lot. We're gonna have a lot of echoed experiences, right? Because a lot of us in this room are either senior NCOs or have been in at least around 10 plus years, right? Myself, I've been in the Army for about 18 years. And even the 4 years prior to me being in the Army, I was in JROTC in high school, which was all Army based. And although it was a high school environment, I still think my JROTC program was one of the most disciplined and like rigorous quote unquote units that I've had within my entire career, which is quite interesting. So, you know, I have approximately 22 years of experience with regards to the perception of physical fitness and being a soldier, or what that correlation means to me. What about the rest of the individuals in the room? So either Sergeant Martin, Sergeant Lopez, Sergeant De La Garza, what conversations do you currently have with your soldiers, or what things do you hear with regards to injuries or pain or discomfort in and out of physical training in your unit? Go ahead, Sergeant Lopez.
So I was just talking, my supply sergeant is right here, and we were literally, while you're giving out the class, we were talking, you mentioned during our last clinic that soldiers need to push beyond where their profile is at currently, because if not, they're not going to get better, right? Because if they have a shoulder injury and they're not moving that shoulder because their profile says not to, they're not progressing on it. They're just, they're just locking it in place and making it worse, creating fascia and whatnot. So we were talking about it's going to be hard to get soldiers to understand, yeah, your profile is there to protect you, but it's not a complete limit on everything you can do, because there's a culture here that it's, oh, I have a profile, I cannot do that. And it doesn't mean you cannot do that. It means you can do it with the limitations until you can't no longer.
Perfect, perfect. So now that conversation shifts, and I saw your hand, Sergeant De La Garza, so we'll get to your question or point next. But now we add the variable of an actual DA 3349, right? So now we get into other forms of potential misconceptions or aspects of our culture as soldiers. We're in an individual who experiences some form of discomfort or pain, whether they're trying to be, whether they have any other intent, to get this piece of paper to stop a test or to stop physical training or not. We'll keep the example of someone just experiences pain. They do their due diligence of seeing some form of a medical provider. Now, most of the time for our population being Compo 3, these medical providers don't have any Army experience. They don't have any understanding of the occupational or physical demands with regards to being a soldier. They may have some type of perception of what that is through different forms of media, social media, books, etc., but they may not have that actual experience. And then this medical provider in this, maybe 5 to 15 minute initial diagnosis of this individual essentially gives them a piece of paper that limits their movement because doing A causes pain. So they give them a paper that says, well, they no longer have to do A. And then for whatever time period that is allotted for when that gets put in the military profiling system, all that happens is that profiler, especially again for Compo 3, that has no communication, dialogue, or further evaluation of that individual. They simply get this civilian piece of paper, and they have to then put this in their system with a series of drop-down lists, which will automatically produce the rest of that DA 3349 that has no particular specificity toward that soldier's capabilities. But the soldier may be completely ignorant of the stepwise aspect of this process. So may the medical provider, and then same thing with the profiler. They're all just doing singular parts that they think is important for the responsibility. And at the end of that, the soldier has a piece of paper that says they can't run, they can't lift, they can't do push-ups, and they may internalize that as what their capabilities actually are, and then therefore they don't do any of these things, and therefore they don't get better. Because as Sergeant Lopez brought up, and we've discussed this in prior injury classes before, the only way to heal a musculoskeletal injury is to engage in some form of movement, which is where you see occupational therapy, physical therapy, and other forms of manual adaptations through rehabilitation reconditioning. So that's something we're definitely going to get into a little bit more. Thank you very much for adding that. Sergeant De La Garza, what did you want to add to the conversation? I see you've removed your mute, but I can't hear you. All right, I'm not sure if someone else can hear him, but he's not coming through. Feel free, though, if you are continually experiencing any type of mic issue, I have the screen up for chat. So if you put anything into chat, I will be responding to it and getting to it throughout this conversation. So go ahead, Sergeant De La Garza, any of the aspects. All right, so while he fixes that issue and types anything out, we'll continue on. Everything's going to be along the same scope for our topic, so we can bounce back and forth as need be. All right, so with musculoskeletal injuries, and let me define that even further, just because, again, we all have different experiences and backgrounds, so we have a good mental scope, or we're all on the same mental page of what we're talking about. There are the concept of injury in and of itself is quite vast. We have many different systems in the body, 11 that we define biologically, and we have two of those are our muscular system and our skeletal system. Now, we typically combine these things because our muscles move our joints, right, our bones. And when we talk about physical exercise, these are the type of injuries that we experience more often, and the ones that we typically have to address as leaders and as human beings in general. I want to be very specific when I say that when we are talking about injuries throughout this clinic, I am not referring to random circumstances of impact injuries or something that is sudden, like a gunshot wound or you being stabbed, punched in the face, a vehicle hits you, IED goes off, some type of concussive force, although those still result in some form of musculoskeletal injury. And some of the variables we're discussing are relative to those circumstances. The primary thing we're discussing here are, you're going to the gym, you're going out in the track, you're out in the motor pool, you're in your warehouse, in your cages, performing patrol, sitting in your office, what have you. And you feel those regular, pains, discomfort within your joints, the soreness within your muscles. And some of these come naturally from our static, which means non-moving, and dynamic, which means moving postures that we're exhibiting throughout the day. Some of these come from the physical activity that we voluntarily put ourselves through, such as the trying to get better, right? Trying to look better, move more, increase our strength, etc. And some of these are just going to come from our general habits, from our daily habits, where we're experiencing pain. So I really want to help through this conversation and other conversations we have, start to reframe how we look at this. But from an organizational perspective, musculoskeletal injuries make up most of the profiles, most of the actual med boards that we have. Even if you look at a combat environment, almost every injury, or at least the large majority of injuries that happen in a combat environment, are non-combat related. They are not IEDs going off. They're not vehicle accidents. They're not, someone being shot at or some form of small arms fire. They are individuals running, going to the gym, lifting something potentially with an already weakened system, or playing some form of a sport, right? Which I've always found interesting because you have soldiers that feel weary or somewhat, what word am I looking for? Somewhat nervous with regards to going out and running or lifting weights, right? They feel that they may be a little bit self-conscious about those movements or it's not for them, but they'll turn around and they'll play some form of a sport, such as, ultimate frisbee, basketball, football, etc. And these sports often have the most physical demand over anything that you're going to do in training. And if you're going to just squat or deadlift, it's a singular movement, it's ergogenic, it's safe, quite easy to learn and perform. But with even playing basketball, you have to interact with other human beings. You're dynamically moving with an object that you're trying to track along all these other people. You're jumping and landing on one leg, moving in all three planes of motion. There's so much going on that your risk of injury is significantly higher than just going out and doing traditional training. So, but these are a lot of experience or areas where we're experiencing these, muscle strains, joint sprains, fractures, and things like that. Okay. Any questions or comments on the content covered so far?
Hey, sound right?
Yep, we can hear you, Sergeant De La Garza. Go ahead.
All right, awesome. Sorry, I had the speaker differently on a mic. No, so going back to the first question that you asked, I just wanted to add up that some soldiers, like stuff that I've seen from soldiers, they take advantage of active duty orders or being in battle assembly to like just go to sick call or go to get taken care of by medical providers, and so that way they can get seen and like they can add up to their VA disability compensation. That they have that mentality that if I go during battle assembly or if I go through when I'm in active duty orders, I will have I will pick up my compensation once I'm close to retirement, or like it's gonna help me with my disability. So it's a mentality that I've seen in the ranks here at the company level, and it's a good one.
No, thank you so much for that. And let's talk about that for a moment. And it's something we've discussed when we talked about leadership in one of our H2F clinics before. But I personally like to look at these circumstances from multiple perspectives. That's just how I view life. I'm a critical individual, right? And I like to play devil's advocate, even with my own initiations of thought. We absolutely observe soldiers trying to ensure they can protect themselves or set themselves up for success, however that wants to be defined. So in some cases, that is an individual fearing a physical fitness test and their capabilities coming up, and then therefore they go and establish a profile because they know they are incapable of potentially performing to a level of their own expectations or the expectations of others. We see the same thing on, as Sergeant De La Garza just mentioned, especially for Composition 3, where individuals that may or may not have adequate health care as a reservist or finances to be able to maintain a good healthcare plan may capitalize on what the Army does provide when on active duty orders in order to both be seen and be evaluated, and or take that to the next level of developing some form of a paper trail for when they do eventually become a civilian again, as we all have to do at one point in time, right? It's guaranteed we will become civilians once more. And we, or they may want to, develop that background in order to be able to increase their percentage for VA. Now, sometimes we look at the soldier and we put that on the soldier, right? We think it may be malingering. We may think they're just trying to, game the system. But as often as I've seen that occur with soldiers, I've also seen leaders advocate for soldiers to ensure that they do get everything documented get everything to the VA, and when they're about to get out, to ensure their percentage is as high as possible. And even within that, that can be broken down into various spectrums. I personally would advise a soldier when they are near retirement, or if something does personally happen to them, to make sure it is documented, because they did give their time, their body and all of their resources to the Army, and therefore, they've earned that privilege to be taken care of both in and out of the service. We luckily do a lot more for service members now in today's day and age when they are out of the service than what we were doing when I came in to the service. And I think that is phenomenal, especially for mental health. Mental health is something that we have not talked about too often, and it's something we don't address as often, but it's, we've made leaps and bounds of changes for mental health for soldiers in general. But without leading down that aside, I want soldiers to be able to document everything, but if we don't frame our conversations as why that's important, or how that process works, that soldier may think inherently that's what they have to do and that's what they should do because that's part of culture. You need to go get everything documented. You should leave the Army with as high of a VA percentage as possible. And that's where it's really unfortunate in my eyes, because I couldn't tell you, working in physical therapy and occupational therapy environments, as well as through strength and conditioning facilities, how many veterans that I've had the opportunity to assist, that most of their injuries, their pain, and their lower quality of life, the issues that they're dealing with, happen because they developed this character within themselves of this injury within their service, right? A bad knee, a bad back, because they feel, hey, I went to airborne and air assault, I jumped a lot, I have to have bad knees and bad back. They associate that as a mandate or as an absolute cause and effect. And then therefore they think, I'm going to get this amount of percentage for my knee and my back. I no longer have a physical fitness test or standards I need to maintain. So when they retire with 80 to 90% disability, they think, this is me, this is who I am now, I need to move less, or I'm not going to move as much. And then, as Sergeant Lopez alluded to earlier, it's the lack of continual movement that further exacerbates their experiences with pain and discomfort and leads to further lower qualities of life. Wherein I would like soldiers to be empowered with the knowledge of what they can do. So it is perfectly fine to document everything, please do, right? And please apply for the VA when you're for everything for VA when you're retiring, but take in consideration how much control you have over your life. If you continue moving, you will still be able to move. If you lack movement, you tell your body movement isn't important, and therefore it adapts to not being able to move. So I think we need to ensure that we have both conversations, and it really starts early in the soldier's career. If we, in our formations, we're talking about make sure you document everything, make sure you get a profile, and we leave it at that, then we're really influencing them to do just that. So at least that's my aspect of what you brought up, Sergeant De La Garza. What are your thoughts, or anyone's thoughts on that matter?
Nah, I would just go ahead. Go ahead, son.
I think you may have been hearing the echo of yourself. Go ahead.
Nah, I would just say, no, I agree. Like, if you get whatever it is that if you're hurt, you're hurt. Go get checked up. But sometimes like they use that as an excuse, and they don't do the proper training that they need to conduct during, like, let's say, battle assemblies, so that they can take care. Like, they make it a priority. That's my issue,
Absolutely.
Instead of like, hey man, like, yes, I have this, but I also I gotta take care of like some stuff at the unit level, like that's my job duty title tells me. So they make it a priority. They don't make it as a something like, hey, I know I gotta do this, but you know what I mean, right? Like,
I absolutely do. So what comes to your mind, or anyone's mind, with if I say a soldier feels that they must get some form of a DA 3349, some form of a profile because of this injury, what are your immediate thoughts as either another soldier or as a leader? with regards to that situation.
Our thoughts when somebody thinks they must get a
Mhm.
profile. I mean, right off the bat, I mean, it's not really, you don't necessarily need a profile, or maybe you do, but it's not really a, don't do this. It may be a profile just to ensure, for instance, I've seen people having like running profiles, but
Mhm.
not like you can't run. It's like you run at your own pace,
Correct?
which pretty much means if it hurts, you are allowed to like slow down a little bit, fall out of the formation maybe. I mean, usually when people think about profiles, it's like, yeah, I'm gonna go get a profile and I cannot do anything at all.
Exactly.
It's not necessarily the case.
I would think if a soldier felt like they need to absolutely get a profile, that they absolutely think something is truly wrong, which they might need to get evaluated for the actual injury versus just going and try to get a profile. I mean, after you get evaluated, that's when the profile is supposed to be given to you.
Okay.
So I feel like if the soldier must, like as me as being a soldier, some injuries that I get, I'm just like, hey, if I stay off of it for a while or I feel it getting better, then I mean, there's no point in me going to get a profile. Maybe it's just hurt at this moment or I sprained something or anything. But for a soldier to feel like he absolutely need a profile, he absolutely thinks something is wrong to the point where he need to be evaluated.
Good. So Sergeant Lightning actually brought up one of the reasons I asked that question. And I want to emphasize, as leaders, questions are some of the, it is one of the most valuable tools that we have. So what questions allow us to do is they allow us to evaluate in the moment several different things. One, the actual potential answer we're looking for, but two, the individual's perception. So to Sergeant De La Garza's point on these individuals, getting these profiles or putting things in the VA system, what I would argue as a leader is we need to try and evaluate that soldier's understanding of the process. So why does that soldier feel they need a profile? What is that soldier's understanding of what this VA process is to them, or why it's necessary for them to take the steps that they're taking? Because just if we see them do something and we assume and therefore attribute their reasoning for doing it, such as we think they're malingering, we think that they are trying to prevent themselves from taking a test. And we may have many different variables that add to that assumption from our experience of observations of this individual, right? It may be a chronic habit that they do. Every single time there's a test, they go on profile. Every single time they come on orders, they end up going to the clinic. We may see this as a habit, but even if we see it as a habit, that doesn't automatically mean that we completely understand why they're doing what they're doing. And then even if that was the case, it still elucidates that they may be ignorant of some pieces of this puzzle. So often what we need to be able to do is not only ask a question, but we need to be able to evaluate their understanding and then try to modify that understanding to the best of our capability through dialogue and general verbal counseling and things of that nature, so that we can try and change the culture, right? We need to be able to change their scope of understanding for this, so that when an event does occur, their behavioral pattern doesn't automatically go from this cause to this effect, right? We need to modify it so they don't feel I'm sore, therefore I shouldn't work out. I feel sharpness, a sharp pain in my shoulder when I try and lift my arm overhead, therefore I need to get a profile and I can never do push-ups again. Right? I'm going on orders, therefore this is an opportunity for me to go to the clinic. Right. It is our job as leaders to try and add some form of reasoning, some type of purpose in between to kind of inhibit that process so they can have a more effective overall mental scheme. Go ahead, Sergeant Lopez.
Hey, sorry. So I got you on the speakers at my office. I share my office with a couple other soldiers. So
okay.
They were reading through the slide, and they're reading injured areas, lower back. And I'm sorry for kind of shifting the subject on you there, but so for example, I have a soldier who has 3 herniated discs, 5 herniated discs apparently, And he's saying like, you know, that he does need his profile and that he can't move his back because herniated disc is not something that you recover from because it's something, it's progressive over time, it gets worse. So I was wondering if a case like that, do you evaluate a case by case basis, or is there a way to start working on him to get his back, you know, into a stronger posture where he could, you know, function properly?
What a valuable question. And never worry about changing the subject as long as it's obviously within the same scope, right? Our conversations are how we learn. So I think that was a phenomenal question. So I'm going to make several kind of wider statements about this to address the various points you brought up. So first, out of all of this, I want to establish that out of almost every form of an injury, vertebral column injuries, so spinal injuries, especially with our population, are some of the most misunderstood. And this is because there has never been any form of clinical research that has shown a direct correlation with bulging discs, slipped disc, degenerative disc disorders, and things like that, and pain. There's never been that type of correlation. And it's very difficult because you have an individual who, in our form of Western medicine, we don't undergo regular X-rays and MRIs. So we don't have any form of a baseline of what our spine looks like. The only time we end up seeing some form of imagery is after we've succumbed to some form of symptoms of pain, discomfort, lack of movement, or some type of inciting event, such as a car accident or etc. And then what typically happens is the individual will go and they'll receive, they are having symptoms, and we don't want to take that away from them, some type of symptoms of pain and discomfort. So there's absolutely something going on. But then when they go and they get medical imagery, this medical imagery shows that they don't have a spine with the exact S curve, that you would expect to see from a medical textbook, or the spacing between their vertebrae may be less, where the vertebrae look like they're touching. So people are told, when the conversation is had, that they have degenerative discs or some type of bulging, some type of swelling. And it's unfortunate because that could have been how their spine always was before they ever even had any pain. And now what they attribute to their pain is that imagery rather than, what's actually going on internally. So if you look at most forms of meta-analysis that are done over the last maybe even 5 to 10 years, in every form of like surgical medicine, you look at like the British Journal of Sports Medicine, you look at different forms of reconditioning, almost every form of dialogue in clinical research has been showing to not use any form of medical imagery, and in fact, to even get rid of the terms bulging disc, slip disc, degenerative disc, because it's not associated with anything directly. Now, that being said, the individual is still obviously experiencing some form of symptoms of pain. So as a clinician, obviously none of us in this room, or either virtually or physically, are clinicians, but a clinician's job is to ensure that the individual, or they can help the individual try and inhibit those experiences of pain. And that may be through some form of a prescription, which that prescription, all it does is numb or inhibit the electronic signal that's going through that specific nerve column. So nothing's changing physically, but the signal of pain just isn't going through, so that person can relax more and they can move more. If the individual actually gets prescribed physical therapy, then what the physical therapist is going to do is start introducing more range of motion, and then eventually more load through range of motion. That way the body doesn't overreact, which is what a lot of these pain experiences are anymore. And then the individual starts experiencing less pain over time because they are actually introducing load and introducing movement. But what generally happens, and it's very hard for me to deal with as well, with my understanding and doing physical therapy for so long and helping people for so long, is having a person come to me and thinking, I have a bad back, I have a bad knee, I have a bad shoulder, and they attribute it so much to who they are that they think they can't get better, or they think they need some type of cervical intervention, which most of the time is absolutely not necessary. The unfortunate part with that too is if you talk to a surgeon, the surgeon is going to tell you you need surgery, and that's not job security. That's their scope of practice, right? That's what they are meant to do. That's their whole job and education piece. But in addition to just listening to me from my experience adding to this, right? You don't have to use any type of Sergeant Rice said this or Sergeant Rice said that. I really advocate that individuals starting to learn more about their body. So resources for that person, specifically with regards to back injuries. For soldiers, there's a wonderful, wonderful podcast done by Barbell Medicine. And Barbell Medicine is one of my top podcasts I would recommend to anyone. Every single one of their individuals that speak, they are all medical doctors. They're all PhDs in whether they are general practitioners, chiropractors, or what have you. And they're also all competitive athletes. And their conversations on pain and the body are some of the best I've seen in the world. But they have a specific podcast for our population. If you just search on Apple Podcasts or Spotify or YouTube for Barbell Medicine Fort Irwin, they have a conversation specifically covering a lot of this on back pain with regards to things like normal soldier movements, with regards to the deadlift and the ACFT. And they say things in that conversation potentially much better than I will. Additional resource I would recommend is Dr. Stuart McGill, which is McGill for last name. He is a Canadian physical therapist who's known actually as the primary back doctor internationally. He's one of the biggest aspects that's chosen for that. And he has two really big or really important books. Actually, they're not big books, but important books I would recommend for individuals that are experiencing non-specific low back pain or non-specific back pain in general, which is The Back Mechanic, phenomenal book, as well as The Gift of Injury. Yes, I'll put those names in chat, Sergeant Coley. So The Gift of Injury is another big one I want to say, because what this was, it was a case study he specifically did with a lifter by the name of Brian Carroll. So I'd mentioned this in one of our classes before, but Brian Carroll was an individual that had the world record for squat, where he squatted about 1,300 pounds, right? So it's any of us can think of, that's a significant amount of weight. Doesn't matter who you are. And he, Brian Carroll, ended up feeling an extreme amount of back pain after he'd broken that world record. And he saw a ridiculous amount of, all right, Sergeant Lopez, if you want, you could just leave it open for the individuals in your office, and I'll see when you come back for your appointment. But he went and saw a lot of surgeons, a lot of physical therapists, a lot of occupational therapists, and every single one of them told him he should never touch weight again, that he had everything that we'd been discussing before, right? He had slip discs, he had herniated discs, etc. And they said, never lift weight again, otherwise you're going to absolutely need surgery, you'll never walk again. Well, luckily, he didn't want to listen to any of those individuals, so he wanted to find someone due to his bias who would listen to him. And it was really good that he did. He found Stuart McGill, who ended up putting him through about 8 to 10 months of return to sport therapy. Now, again, we're taking an individual that was able to put 1,300 pounds on his back. In the first 4 months, Dr. McGill had him do nothing but do squats with a barbell. So just 45 pounds. It's something that is extremely easy for this person to do. And he focused nothing but Brian Carroll's posture, and focused on ways to increase stability, global stability throughout his system. Now, at the end of that entire reconditioning system, Brian Carroll went back and broke his own squat world record, and has since, according to him, been squatting and moving without pain and without discomfort. And this is him going across the country, experiencing, the same thing our soldiers will once, with a medical provider saying, this is your slip disc, this is your herniated disc, etc. And I want to say that because I think it's an empowering story to try and point out the fact that that's not the end of the game. In fact, the only way to limit that pain, because hopefully you don't want to be in pain forever, is to load that system. Is to teach the body that it's okay to move, that it's okay to have weight on it. And the only way to do that is through movement and through weight. All right, so I'm going to put those names in the chat. But any questions or comments on any of that?
When it comes to injuries, sometimes it's just about, because nobody knows what you're feeling better than you. Because you're the one feeling the pain and what movements are limited and whatnot. And I think most of it is all about, getting to know a little bit better, like getting to know your body a little bit better. Like,
Absolutely.
when I do this, it hurts. So what can I do to mitigate that pain? It's not necessarily stop, but if it hurts, if my knees hurt from when I'm running, maybe I have to think about what kind of surface I'm using, like whether I'm running on the streets, I'm running on the track, is there hills? It doesn't mean you have to stop running, hills or whatnot, but maybe do it once or twice a week instead of doing it all 5 days a week.
Very good point.
Back in the days, I used to run 6 days a week, even though I hate it, and it was great. And, nobody would hurt or anything. Today, it's like, I may be limited to like 3 times a week, or if I feel good, but it's all about knowing, getting to know yourself a little bit better and looking for ways to mitigate, the pain you're feeling and whatnot, depending on of course, your routine, your daily routine, and then the resources available, of course.
Absolutely. And I'm putting one more resource into the chat here. And I also know we need to move on to the slides, but I completely agree. Pain is an individual experience, and it doesn't matter how many individuals I've worked with or you've worked with and trained, or whether as a drill sergeant, as a leader, or as a coach, trainer, athlete, everyone's going to experience pain differently. And what we typically see, you go into a clinician's office, and if they ask you, like, where's your pain on 1 to 10, it's a sometimes useful metric for the clinician to understand the individual's perception of that pain, but it's extremely arbitrary. Because you being at a 7 out of 10 and me being at a 7 out of 10, even if I tell you what my idea of a 7 out of 10 is, right, it's still going to be completely different. And so we have to take it at face value, but also understand that the person's own understanding of pain in their body is going to change their perception. All right, so as we move forward with this, acute injuries itself, acute typically meaning in the moment, like something that just happens, as you see in the picture, which would be like a lateral ankle sprain, right? So that right foot going through plantar flexion and inversion to the point where the ligaments and tendons involved aren't used to being at that range of motion under gravity and the individual's own body weight, and then therefore the body compensates quickly with that injury or with that range of motion, that length change, and we perceive that as an injury. Now, there's a difference when you see something like this happen and then the person has like a swollen ankle, they have heat in the area, right? Edema, excess inflammation. Those are clearly indications of some type of tissue damage that also attribute to the symptoms of pain. But once those observations of swelling and heat and, color discoloration rather are gone, and that person's still experiencing pain, it's not that all the tissue damage is gone, but more than likely, we're no longer looking at tissue damage as a primary factor of the injury or the pain that person's experiencing. Now we're typically looking at a form of receptors. We're looking at a form of habits that the person's body and those receptors have attributed to that area and to that movement. Right. So from here on out, as we continue our conversations on pain and injuries, I want you to try to attribute this to the analogy of a car alarm. Right. There's many reasons your car alarm may go off. It doesn't just mean that someone's breaking into your vehicle. Right. A child could have kicked a soccer ball. There could have been an earthquake. Another car could have driven by too quickly. There's a lot of different things depending on the sensitivity of your car alarm. But what happens generally is an individual experiences pain and they think they are injured, which is not always the case. So they think they're injured, which means they think someone's breaking into their vehicle. And then every single time that they experience that pain, that's the first thing that happens, the first thought process that happens, whether it's a conscious thought or not, wherein it could just be the body's been accustomed to and is now more sensitive to changes in length in those associated structures, changes in pressure to those associated structures, depending on how we're sitting and moving, right? Because we always have gravity as a constant perpendicular force. And then the body's sending a signal to that receptor, the receptor sending a signal back, And the only thing we can interpret from that signal is pain or discomfort. Those receptors aren't complex enough to be able to send anything but a 1 or a 0, right? Either they're on or they're off. They're not necessarily telling us, hey, I need you to adjust 17 degrees, in this axis. It's our body doesn't communicate like that. It doesn't have any form of complex thinking. All we can do is have this overall structure isn't where I think it should be, or isn't where it generally is, and you receive the signal, and then before you think something's wrong. An easy way to also look at this is commonly for those that crack their knuckles. If you crack your knuckles often, you typically feel at a certain point in the day that you need to, right, because you have some form of potential discomfort, right? And cracking the knuckles doesn't change any form of structure or tissue, especially in the knuckles. They're all synovial fluid. They're a synovial joint. So when you crack your knuckle, it's a gas exchange where it's basically a bubble going from one side of the joint to the other, or a bubble popping, right? That's what's going on. And when you have a certain form of fluid accumulation, whether that's a change of your environment because of temperature change, or some type of change of your dietary intake, so salt and electrolyte change, stress can also modify that, where all that happens, or even you change elevation, so pressure changes in the area, your receptors are sending a signal for pressure, you feel discomfort, and you've patterned that when that discomfort happens, what you need to do is crack your knuckles. And then you feel some type of global release of tension, even though you didn't change anything, and you feel better. And so we always attribute this to some form of correction to our body, right? I want to go and correct my joint. I want to be able to go and crack this area. And we use a lot of these terminologies for it, but realistically, you're not changing anything on your body structure, and you can't. If I could put my hands on you and literally change your body structure and your joints, our life would be extremely difficult, right? You think of how much force you put into the ground when you run. In inefficient run form, you could be putting 4 to 8 times your body weight through the ground and through, back into your body through ground reaction forces. That's a lot more weight than I could ever put on you with my hands. So that would mean almost every single time you took a step when you run, you'd be completely changing your entire physical structure. So it doesn't happen. But we think about that, right? We think my back needs alignment or my joint needs alignment. Your joints don't come unaligned. That's not something that occurs. We do have length changes in tissue, and again, our receptors will constantly read these length changes and therefore tell us that we are feeling uncomfortable, so we need to feel we need an adjustment, or we feel that we need an adjustment, I should say. But that doesn't inherently mean that there's a problem within the body. Okay? Any questions or comments on that? No? All right. Up here, typically, the variables you see on screen are the ones that attribute the most to the experience of pain, especially in an acute setting. So if someone was in a prior experience, they'd felt that they had injured their shoulder or their knee or their hip, those receptors involved, especially your proprioceptors with like your muscle spindles and your Golgi tendon organs, those receptors and those that regulate light touch, hard touch, vibration, because we have receptors for everything, those become more sensitive, similar to that car alarm. Once it's gone off, it's more sensitive. Now, on top of that physiologically taking place, you have the cognitive aspect, because our musculoskeletal system is voluntary in nature, right? Those are the 2 of our 11 systems that we can physically change through thought. So if an individual feels every single time they squat, they're going to have low back pain, they're going to be at a higher incident rate of experiencing some form of non-specific back pain through a squat, because they're essentially troubleshooting in that area. They're sending electrical signals to that area to probe for any differences in change. And then if a receptor does feel that experience or change, and it sends that signal back, their bias is reaffirmed that yes, there is something that isn't quote unquote normal, and then therefore I feel pain or discomfort. When you, again, may not be injured, whatsoever. Right, so prior injury has a huge incidence rate for that. Physical activities such as sports. So I know it may seem counterintuitive because we're talking about physical activity being what you need to do to rehabilitate. But as aforementioned, sports and the complexity of the biomechanical patterns involved with playing sports is a huge risk of injury. If I can't take an athlete and have them squat to a decent depth, or I can't have them do a quarter squat and a jump with a good landing mechanic, how would I expect them to go play basketball and jump and land on a single leg, dynamically involving with someone else, right? Jumping around someone else, landing on an uneven surface, if I can't have them do it in a safe, confined manner with a decent or efficient squat form, right, or landing form. So we have a big mechanic there. Males, as we've discussed before, this typically is from culture, right? Whether this is pride, an individual feeling that they must do something better than someone else, or they have certain type of expectations to maintain on the physical aspect. And there's a lot of different kind of epigenetic variables that come into this. MOS and unit requirements, right? Obviously, our combat arms and engineers are going to have a significantly higher physical demand, military police as well, than some of our quartermaster or human resources might, or at least in a different capacity, right? So quartermasters can have an extremely high physical demand, but in a completely different capacity than like an infantryman will. Age is a huge one. How often do you hear people attribute injuries and pain to age?
No.
Yeah. I'm over the hill, right? Go ahead, Chandela Garza.
No, I said very often.
Yeah, it's almost a one-to-one relationship in our culture, right? I must feel pain. I must be slow. I must have a limited range of motion because I'm older. And that's one of the saddest things I think I hear, because people completely remove control of their life when they do that. And if they're saying it out loud, they likely believe it, at least to some extent. Age has nothing to do with feeling pain. Age has nothing to do with limited physical performance. It's the lack of consistent physical performance, the lack of still trying to progress in physical performance that leads to a lot of the pain and discomfort we have. So another piece that I feel is very disheartening is when people think, let me leave all of the heavy lifting, all of the fast running, all of that fancy stuff to the young people. Now I just need to be able to do general movement. And when they do that, that's exactly what they're training their body to do. They're training their body to be weaker, to move less, because the body, again, has no moral compass. It doesn't see you moving less as good or bad. All it does is it starts looking at, or excuse me, all it does is it reacts to the information that you give it based on priority. If you do something often, it gets better at that thing, and it's to the capability that it is able to get better, right? If that individual is fueling it themselves and resting enough in order to facilitate them getting better, then that's all that takes place. So it's very, very important that we try and change that dialogue where people don't attribute age to injury. Any comments on that piece? Because I know that's so commonly thought about.
I think your circumstances make you self-conscious about injury sometimes. Like it's more like usually you see a lot of military people injured and whatnot, and then civilians are like, it's I mean, it happens, but it's not as often as in the military. Maybe because we think, it's a military, the Army breaks us, and plus, when you get out, you probably have a, like we talked about earlier, compensation and whatnot. And we're self-conscious about these stuff. Whether if you don't get anything out of it, you probably don't even care about injuries. Just think about, I have to go to work regardless.
Yes.
Pain or not, it's I gotta go. So it adds up, I guess.
So that's another big piece, right? Our expectations of our responsibilities, and then how that attributes to our prioritizing of information, right? So if you're younger, you think that, hey, you're a younger soldier, you may have opportunities to go to air assault, airborne, all of these fancy schools to get badged. As an older soldier, we may think, well, I have a meeting to ensure I can be ready for my meeting that finally prepares me for my meeting, right? I'm not trying to necessarily score higher on the ACFT because I may not have a promotion in my future. I may not have to worry about, that competitive aspect anymore. And then therefore, because they've attributed physical fitness with a need for schools, physical fitness with a need for promotion, rather than their own capabilities for longevity and overall health and capabilities. Now, when those requirements are gone, therefore now their quality of life starts to go down as well, right? Because they do start adding to these other responsibilities. But again, it's a valuable piece of information, and it is also unfortunate. There's no reason that you can't be 70, 80, 90 years old and squatting and deadlifting twice your body weight. And just the very thought of that to some extent makes people kind of self-conscious and feel like, oh, that's absurd.
Right.
Right? But I mean, if I can have an individual in their 80s deadlift twice their body weight, do I have to worry about them getting in and out of a chair?
No.
Not at all. Do I have to be able to rehabilitate them to learn how to use a walker, as I've worked with World War II veterans, just trying to get them to understand how to, again, get in and out of a chair and use a walker, because they've been immobile for 20 to 30 years after retirement. And then again, they attribute it to age. Now, do we have some form of degradation with age? Potentially, but that doesn't directly result in pain or lack of performance.
Case.
Exactly. So it's the way we look at that cause effect. Higher BMI is the other one that's the most unfortunate to me, and the other sad piece to me. I can't tell you how many soldiers I have had conversations with that feel they can't lose weight because they can't work out. Where some of the first things that come out of their mouth are, I've been having a hard time with COVID and all those other things because I couldn't get to the gym and therefore I gained a lot of weight. And we've discussed this before, but exercise has nothing to do with weight loss. Right. Exercise can certainly facilitate an easier path to better body composition, but it has absolutely nothing to do with weight loss. So when individuals don't modify their dietary intake and they allow themselves to gain more adipose tissue, right? So a lot more fat mass. Not only are they greatly introducing the risk of injury through musculoskeletal injuries, but as we've discussed before, higher BMI, a higher body mass index, more specifically, more body fat percentage rather than just BMI, if we really wanted to be accurate, that increases your risk of everything, right? So cancer, dementia, diabetes, blood pressure issues, everything. And sometimes individuals that get in this very bad cycle where they're overweight, therefore they're not exercising because they feel that they've already kind of passed certain scopes, or they're hurt. They feel pain and feel discomfort, sometimes because they're overweight, and the pain that they're feeling typically makes them feel that they can't exercise because they're in pain.
And also, this also translates to poor movement. Like,
exactly.
If you're overweight, some of the movement may be limited. So people may think that because that happens, they can't work out.
Exactly, right? So they prevent themselves from getting better because of the thing that is not letting them get better. And it just creates this cycle to the point where a lot of people, unfortunately, way too many people, end up getting older, getting more overweight, and feeling there's nothing they can do about it, rather than having the control and the power to understand that they can. Okay.
It's almost like, I always say my show, and everyone per se, it's like the world's not going to adapt to your needs. You have to adapt to the world. So
yes.
If the circumstances are not perfect, then so be it. Instead of looking for excuses, look for answers and different opportunities to like get better.
Absolutely. What can you change? Mm-hmm. If you can't work out 5 days a week, that's fine. You can't work out for an hour at a time, that's fine. Mm-hmm. You don't have a gym membership, it is okay. What can you do in your circumstances? There is always something you can do. And if you don't know, that is also fine. But coming to the degree of self-awareness to understand what you don't know, and then as a leader as well, especially as a leader, being able to recognize that you may not know enough to be able to help your soldiers is critical. That's kind of why H2F is coming about and why H2F exists, and why we have CTAS here now, so we can start having educated leaders in order to be able to help our soldiers from a lot of these inefficient practices we've had before. Good. And the last piece is poor programming, which comprises of our class that we had on Tuesday for optimizing physical performance. A lot of times individuals that do try and take the right, we'll just say they have their own due diligence to try and improve, but then they follow potentially suboptimal practices. They try and run too much. They try and go from the couch to running 2 miles or 3 miles when they're not an avid runner because they know a PT test is coming up. Well, going from 0 miles to 2 miles is a significant increase. There's no reason that you have to run 2 miles, right? You can start with a quarter mile, start with a half mile. There's no reason you have to start with running, right? You can jog and walk, and there's many other forms of things you can do. We need to understand how we can help our soldiers know where to start. And then the next critical piece is how to progress. Because, lifting lightweight won't make you better at heavyweight. Running slow won't necessarily make you better at running fast. So if you need to be able to lift heavy weight, I need to get you to lift heavy weight. And I don't need to be able to take 6 to 8 months to get there. I need to be able to move you into that position quickly but efficiently, which requires a decent understanding of programming. Okay. Any questions or comments before we move on to the next slide?
Negative.
All right, so acute injuries, what we're having in the moment. Overuse injuries, as the name typically implies, are what happens over time, right? So overuse injuries are typically forms of trauma that occur because we aren't allowing the tissue to recover enough, or we are consistently introducing force and changes of length in an area that our body is not accustomed to, right? And again, we don't give it enough time to recover. So if just looking at the pictures, and it's very interesting how visual stimulus can attribute to certain forms of understanding. So you see like a picture where it's quote unquote a normal knee joint, and then another one with potential arthritis. And arthritis just means long-term or chronic inflammation. Whenever you see the suffix of itis, it just means inflammation. It doesn't mean that when you have arthritis, you have it for life, which is another really, really, really common misunderstanding. It just means that based off of your daily habits, you have, or your current body structure is more prone to inflammation in this area. So then the response that you need to be able to have and the movement you need to be able to have is going to be different than if you don't have that situation, right? So like if I have someone who's more genetically disposed to being diabetic, right? So their resting blood glucose levels are higher than another individual's, their dietary practices should look different. But it doesn't mean that that person that is predisposed to diabetes never needs to have sugar or carbohydrates, right? That's an extreme form of reductionism based off of that situation. Same thing with arthritis, whether it's in the wrist, the knee, doesn't matter where it is. It just means you're more prone to inflammation based on the activities that you do. Therefore, you need to be more aware of how to address it than someone else will. So instead of backing off more and just not doing anything, you need to figure out what you can do. That way you're not constantly experiencing pain. And then I added the picture of the spine specifically for that same reason for what we talked about earlier. Right, just looking at a spine and looking at vertebral discs and thinking this one isn't aligned, or this one looks like it's touching, or this one looks like there's swelling, that's irrelevant. In fact, I think one of the best studies I've ever seen, best meta-analysis I've seen on the back, quite recently, I think it was in the last 8 months or so, came from the British Journal of Sports Medicine. And what they did is I think it was a Swedish study actually, they were looking at individuals, they were performing MRIs on healthy individuals that weren't experiencing pain. What they did is they had them do a workout and then they gave them an MRI after every workout. And what they saw is they did a baseline beforehand, obviously to see how the spine was going to look. And every person during the recovery from intense workouts showed symptoms of various spine issues in the MRI. And what they hypothesized was the fact that since your spine is part of your central nervous system that involves around everything, that's regard to spinal fluid or sending that electrical signal, etc. They hypothesized that just the aspect of recovering from normal movement typically increases tendencies for the spine to show areas of like bulging disc, degenerative disc, even if there's not some type of long-term issue. Because when they allowed that person to recover more and they weren't experiencing soreness or fatigue from the exercises, the spines returned to the baseline of what they had before. So I think that was a very fascinating study. Now, our overuse injury factors are going to be very similar to our acute injury factors. These are typically the poor programming is going to be an even bigger piece here, right? Because you have individuals that are doing something potentially inefficient for a longer period of time. You're also going to see females up here. Now, that's an interesting piece because females have been shown to actually recover from exercise, heavy exercise, or I should say intense exercise to be more specific. Females typically recover from intense exercise faster than males, but because they have less testosterone hormonally, they don't recover from musculoskeletal repair as much as males. And then with our population as soldiers, when we do the old school aspect of training as an organization, especially running, if a female has to keep up with a male with their longer strides and that female may be shorter than the individual, as well as a female having thinner hips because biologically they're designed for childbirth, they're at a greater risk of formal neck stress injuries and other forms of hip and knee issues due to and back issues, particularly due to compensations from those biological matters. Okay. Questions on anything that you see on screen or something I've said? All right. So, I'm going to use this slide to get into what kind of the meat and potatoes, so to speak, of what I wanted this discussion to be about. Although I feel all of these variables are important. So what you kind of see here is the natural process of tissue healing. Now, this tissue healing process that you see from our inflammation to repair to remodeling phase happens both when we have an unplanned introduction of tissue damage, such as an injury, right? Whether that is you feel you pulled a muscle, whatever that typically means to you, or you've twisted an ankle or what have you. This process happens when those situations occur. This process also happens through normal exercise. When you go and you're trying to run, bike, swim, lift weights, etc., you're introducing purposeful, systematic damage to your body in order to give it the information of how you want it to improve. So if you go and you had a very efficient planned deadlift day with all of the accessories, proper warm-up, proper cool down, etc. Once you finish that training session, your body's already introducing and increasing its inflammatory response. Because your inflammatory response comes from your lymphatic system, your immune system, and it is our body's primary healing method, which is why you see 0 to 7 days. So you perform that deadlift, you would generally be advised to recover between about 24 to 48 hours before loading that type of movement pattern again. What this does is it allows the inflammation to do its natural healing process, wherein your body's going to lay down collagen fiber, and those collagen fibers initially are quite malleable. They can move and break pretty easy, but as you don't go through and load those movement patterns heavily, those collagen fibers will start to harden, in which they can actually start to produce force, and then now you've potentially changed the cross-sectional area of your muscle or your ability to move, which is where we see ourselves either getting bigger, stronger, etc. However, when you interrupt that healing process by training too often, by doing too much, then you don't allow those collagen fibers to recover properly. And then we get to a position where we may have some type of overuse injury or some type of supercompensative response in some form of receptor that tells us we're feeling injured or that we're just having some form of discomfort, even if we may not have some type of physiological issue. Got you. The other part of that is, on the other end of the spectrum, I should say, is if someone goes to work out and they feel they've hurt their back or shoulder, or they feel they've tweaked something. One of the biggest mistakes in those situations are the individual stops moving. Oh, let me take a week off because I hurt something. Well, when you introduce damage and you do take a full week off or longer, right? A week is an arbitrary metric, right? But just you take too much time off. Those collagen fibers, when they're laid down, are laid down rather haphazardly. They're not necessarily laid down in the same direction as the rest of the striations in your muscle, right? Those straight lines in your muscle that go from origin to insertion for, an easier form of conceiving that. So when it's laid down, say, perpendicular to the rest of your muscle fibers, and you allow it to heal in that manner, well, now you've potentially reduced your capability of moving well. So then now when you go to move again, your limitation in movement, even if it's only a centimeter at a time in different areas, which we don't perceive, it does, exactly, Charlotte. It triggers our response of pain and discomfort. And then that reaffirms the individual's bias of, oh no, I do have an injury, rather than them correlating their lack of activity to the pain response that they're experiencing. Right. Now, if you do have a more significant injury, then of course you'll have some of the aspects you see on the bottom right of that the piece, right? So when you have an acute phase, you may have a blood clot formed, in which what you're seeing there, the straight lines would be the striations of the muscle fiber. And then when you have inflammation and more blood in the area, because blood is what brings oxygen and nutrients to each of our actual tissue structures, that it lessens space, right? So as you push and you add more volume of fluid in an area, all of your receptors, which are hypersensitive, start to send more signals. So just the slightest amount of movement or the slightest amount of touch tells your body you are in discomfort, you are in pain, because there's less space in the area that would naturally be there. Then when you see in the second picture, some of those fibers being laid down as the clot's starting to shrink. As you get to the third phase in that picture, this is where if you're allowing movement to occur, you're actually going through range of motion, whether that's loaded or not. You start to pull those collagen fibers in the correct direction of the rest of the striations, which ends up getting to the last picture where you're actually remodeling to get better. Now, this entire inflammation to remodeling phase can happen within a 48-hour window for normal workouts. For more significant injuries, of course, this can last up to like a year. Right? You think of having like a grade 3 ACL tear, you're not going to recover from that in 48 hours. Right. But you need to be able to teach your body how to go through that recovery process. Any questions or comments? All right, so what you can do in the moment and how we can start framing the thoughts for our soldiers. The old method taught in Combat Lifesaver course for 68 Whiskeys and in general for undergraduate exercise science and medicine was the RICE and the PRICE method, which stood for rest, ice, compression, and elevation. And they eventually added protect, rest, ice, compression, and elevation, which are the old aspects. We've largely seen through meta-analysis that those are ineffective for acute injury care and rehabilitation. The first thing you need to do if you have a significant injury is to protect it. The protection typically happens for the first 48 hours, unless there's some form of like a complex fracture or some type of bone fracture, right? A compound fracture or even a simple fracture for the bone. If we have a fracture of bone, because bones are living tissue, they require a lot more time to heal and a lot more sedentary, or at least need to be more static, right? So less movement. Those are a little bit different circumstances. But for our ligaments, our tendons, and our muscles, after the first 48 hours, you need to start moving the area to allow it to heal properly. The elevation aspect comes in due to the fact that our cardiovascular system is largely gravity fed. And this is even more important for our legs than anything else. So your arteries have no valves. Your arteries send blood to your capillaries throughout your body, and then your veins pull, all of the acid that we produce back in through our heart and into our lungs, back to our veins. But our veins have valves, and those valves largely stay healthy with movement. Right? Our natural contraction of our skeletal muscle, the shortening of that muscle, puts pressure on our lymphatic system, our lymph nodes, because our lymph system, which is our immune system, runs in parallel to our cardiovascular system, our veins and our arteries. So it pushes everything back into our blood system so we can get rid of it. When you don't move, you prevent that from happening. And with elevation, you aid in a lot of the extra inflammation and stuff within your lower extremities to be able to come back through the heart and to get rid of that due to the effect of gravity. You'll notice that third bullet is to avoid anti-inflammatory devices, so NSAIDs, which are non-steroidal anti-inflammatory devices, such as like Tylenol 3, ibuprofen, things of that nature. To avoid that and to avoid ice. What we've seen for most acute injury repair and modification is the fact that anti-inflammatory, although it's very useful in a situation where you're experiencing discomfort and pain and you just need to be able to get through the day, get through your mission, in those cases it's fine. But whenever the individual can abstain or keep themselves from using ice or from using anti-inflammatory, it's more beneficial because, as aforementioned, your inflammation process is what allows you to heal. So you do not want to limit your inflammation unless you absolutely have to. Compression, similar to movement, helps by, again, when it comes to edema and kind of extra fluids from inflammation sitting in around the area, helps push that back into the capillaries, so our veins can help transport it through our system. Also, what's the first thing that happens if you're walking through your house and you hit a coffee table with your shin?
It hurts. I tell you that.
Yeah, feel pain. What else?
Say ouch.
You say ouch, and what do?
You protect it. You grab your leg real quick.
You grab it. It's a biological response. Pressure, due to how our receptors work throughout our tissue structures, pressure helps typically inhibit that pain response. So you can only send and receive a certain amount of stimulus at any point in time. And as aforementioned, you have certain receptors that kind of say you have light touch, hard touch, vibration, changes in temperature in comparison to your body temperature, and that's how we interact with the outside world. So when you grab an area and you apply tension to it, you are seemingly over inundating a stimulus of that area through those receptors, which inhibits some of the pain response that you feel. Right? You're not healing yourself. You're not helping any type of perceived injury in any way, but you are limiting some of that pain response. So compression can help with that. The next piece would be education, which is what we're doing now. Right? Most individuals feel they're injured because they don't understand their body enough. Right? If I have soldiers, I'll give you an example. In the Master Fitness Trainer course, we used to do our speed and agility day, in which we would have each of our students do the 40-yard sprint. And it was almost guaranteed every single class, if we do a 40-yard sprint, 1 out of the 30 may feel that they've pulled a groin muscle or pulled a hamstring. Well, that's generally because they're introducing a high amount of force and a very fast rate of change for the length of those tissues that they don't normally do, right? So it's the lack of movement that typically introduces risk of injury. But every single time this happened, the first thing I would do with that student is I would go up to them and I'd have them continue moving and then move their joints, particularly their knee and their hip, through different ranges of motion to help them understand, and I'd verbalize as I had them do this, the fact that they aren't significantly injured. If you can still take your knee through flexion, you can still take your hip through flexion, extension, abduction, adduction, etc., through the different planes of motion. If you can still do that range of motion, even if it's somewhat limited, you may not be significantly injured. Likely chances you're not. Now, it may be painful because, again, your car alarm is going off. Right? So you're getting a lot of these signals, but it doesn't mean you shouldn't move. So I would walk with them for a few minutes. I'd have them continue range of motion, and I'd have them continue putting force on that area in order to alleviate the response that their brain was currently receiving. And it's the same thing I would have people do in the gym. If you're deadlifting, squatting, benching, etc., and you feel tension in your back and your shoulder, especially if you feel like you've tweaked an area, generally one of the best things you can do is put the bar down or put it up, rest maybe 3 to 5 minutes, focus on that area for your body, so you understand that you can go through range of motion, maybe go through the range of motion without load, then get back under or above that bar, lighten the weight maybe a little bit, and move it again. Because going through that loaded range of motion is one of the best ways to get your body to stop overreacting, which are where a lot of our symptoms of pain come from, are simply overreactions of our body to some form of stimulus. Right, so I add that that educational aspect to my athletes and my clients, my soldiers, when I'm working with them, so they don't mentally feel they're injured because their body's already trying to hold back. So if they mentally also try and hold back, all they do is compound the issue and they exacerbate it, which makes them more likely to experience symptoms of pain and discomfort. Load follows the same thing that I just discussed, right? We're always under the same load of gravity because it's a constant force. And gravity plus our body mass is what gives us weight when we have some type of line of support with the ground. So the more body weight we have, especially fat mass, which doesn't attribute to us preventing pain and having performance, and then the lack of resistance training makes our body more sensitive to movement. If I'm able to get you to load your spine, load a joint in general with an external, some form of external resistance and progress with that, you're less likely to experience pain and discomfort just from sitting down all day because your body's able to undergo force development much differently. I'm working on your load capacity of your joints. Optimism is another big piece, as we discussed before. This comes into the resiliency aspect. If a soldier doesn't know they can get better, which is the education, and their leader doesn't have a conversation with them on how they can get better in order to provide resources, they may start to attribute that injury to their character. They may start thinking they have a bad back, and as soon as they start thinking that they have a bad back, they start changing how they move, how they interact, how they sit, and all of the other behavioral patterns, which will only make their situation worse. Vascularization comes in from cardio exercise. So doing things such as running, biking, swimming, and if running seems to be a chronic issue, then non-impact cardiovascular training such as biking, swimming, and using endurance training machines could be efficient because getting the blood flowing, getting that heart rate up helps pull nutrients and oxygen for better repair of most of our structures. And then exercise being on there also in addition to load and vascularization is different in the frame of when it says exercise, it means specifically range of motion, right? So if you feel you have a difficulty getting your shoulder overhead, then you need to work on systematically getting your shoulder to an overhead position. Okay. It is very important to understand that if I have a soldier that feels they're in a 4 out of 10 pain, for an example, and right now they can only raise their arm parallel to the ground. If I can get them eventually to get their shoulder overhead and they're still at a 4 out of a 10 pain, I need that soldier to see that as a win. It's not always the fact that you are completely pain-free. It's your capabilities of moving with pain and with discomfort are huge wins. So if I can increase the amount of weight you can move and or the amount of range of motion you can go through, even if you're experiencing the same degree of pain or discomfort, we are on a huge, huge, huge platform for success. Any questions, comments, or concerns with that? And welcome, Sergeant Boyer.
Hi.
All right, so the next few slides are just going to be talking about exercise regressions and modifications that can happen for where our soldiers can either get started or what we can do once they felt that they were trying to run, they were trying to lift, and they have, to their perception, a significant injury that they need to be able to modify. So the first part of exercise regressions comes in at limiting overall range of motion. I don't prescribe, or I don't subscribe to the thought process that an individual needs to lower the amount of weight that they're lifting first, or that they need to completely remove or abstain certain movements. It is usually much better if the person still does the same activity that they felt pain in, but they simply reduce the range of motion first. I have these pictures and these slides in here as a reference point for later on, but we're going to get deeper into this conversation in our next injury class, in which we are going to be talking about how we're going to be reviewing profiles throughout our brigade in order to ensure we can keep them up to date and establish a reconditioning program. Now, you can use strength training machines separate from free weights such as barbells and dumbbells because they allow for the individual to go through typically a full range of motion without having to stabilize internally. And if the individual can go through that range of motion with an ETM or STM, which is an endurance training machine or strength training machine respectively, without the same degree of pain, that is a really critical factor to understand, because this means that it further reinforces the fact that there's not a significant injury, some type of physical tissue damage within the body. There's just a limitation in that current range of motion and the capabilities of that action that are preventing someone. So let me give you an example. If someone's telling you that they feel back pain when they squat, and you ask them to sit down in a chair and get out of a chair, and they're not feeling the same back pain, squatting isn't the issue. Right, for them, currently, the weight may be. And that may be a placebo effect, right? It may be how they attribute that load. So now we know that the range of motion and the action isn't the issue. How do we get them to start increasing the load so that their body stops overreacting to the squat pattern that they already do every time they get in and out of a car, on and off the toilet, in and out of their office chair, they're performing a squat. So they can already do that without pain. How do we get them to mentally understand and then physically with consistency start introducing that movement pattern with load so that the body doesn't start overreacting and they think they are injured? Right. So range of motion and using ETMs and STMs for that are a critical piece. Right. ETMs specifically because running has the highest risk of injury outside of sports out of anything that we can do. Running has an almost 80% risk of injury, predominantly because individuals are never taught efficient running form. And so the inefficiency of their form greatly introduces how much ground reaction force they're experiencing, which, with the amount of volume that's introduced with running, right? If you run a mile, you could be doing over 2,000 repetitions with regards to steps with that ground reaction force. So it introduces a lot of damage to the body that person may not be able to recover from. Without introducing proper, obviously recovery techniques, proper nutrition and rest, and then knowing how to program efficiently. So ETMs help with that because they help reduce overall ground reaction force while still introducing a cross-training effect for the cardiovascular system. But inherently, we need our soldiers to run, especially if they have a running profile. Those are the soldiers we need to get to run. The soldiers we need to focus on running the most are those that have a running profile. Right, and Sergeant Rivera brought this up earlier. Running profiles all say run at your own pace. And you will never get rid of a running profile if you do not run. So one of the things that we need to do as leaders is when we have a soldier on running profile is to allow them to run. We can't make them run, but we can educate them on the importance of it and how to run effectively, so that as they start introducing this movement pattern into their habits, they can start doing so less pain or more pain-free and more pain-free. The Army already has some processes established as far as protocols to do this, such as a walk to run progression program. Now this is generally a 5-week program, but this could take more or less time depending on, the severity of that individual's injury, the severity of that person's perception of pain and injury, as well as how consistent that individual can be with introducing this movement pattern into their daily behaviors. Any questions? All right, so I'm going to use this actually as our last slide, predominantly because we have a lot to talk about with regards to injuries, especially within the comprehensive tactical athlete system, because we have an entire reconditioning program that we need to be able to develop here from scratch, because nothing exists at the moment. And reconditioning program needs to be done at a brigade level. Not that the companies need to have their own thing, because they do, but in order to encompass all of the different severities and complexities of injuries. So moving forward, one thing I need each of you and our soldiers to understand is that a 3349, even if it has a permanent on it, if it's for physical aspects at least, doesn't mean it's for life. And the last thing we need our soldiers to think is that they should have a profile for life or they have a physical limitation for life, because there's practically no physical injury they can have that they can't recover from while they're still in the service. I've worked with double amputees, single amputees. I've worked with individuals hit by a bus. I've worked with individuals, especially with regards to special forces, that have been in, that have been shot a dozen times, IEDs going off, et cetera. And they're still some of the top performing people I've ever worked with in the service. The hard part is knowing how to recover, what to do to recover, and then the fact that recovery itself is going to be painful. Reconditioning is a process that is uncomfortable. It hurts, but we must do it we must push through it and know how to push through it properly in order to actually recover. And what we're recovering isn't just our ability to do the PT tests. As soldiers and as leaders for our soldiers, we need to get them to understand that their recovery, what they're gaining back, is their life. We need them to, outside of uniform, feel they can wake up, move, play with their children, go for a walk with their dogs, or do whatever they need, pain-free. But it starts now with education and training to get them there. All right. So to close this out, I want to know if you have any questions on content that we've covered. And/or I really want to know, how do you plan on taking any of the things we've talked about today and actually using it with your unit?
The education portion is definitely something I would try and do at the unit level, especially because I have quite a few soldiers on profile. Most of them are overweight, which is not healthy. Not only the Army tells you not to be overweight, but also for health reasons, it's good knowledge. And a lot of these soldiers start to attribute their condition to these injuries and profiles they have and whatnot. So educate them on how to understand their bodies, their injuries, and how to progressively get out of them and try and do their best effort to better themselves and whatnot. It's important, not only, like you mentioned, not only for the Army purposes, but also for their own lives. Like, if you're overweight now with 27 years old, what can you expect from here in 10 years, 20 years?
Very good point.
It's not going to get better if you don't do anything about it.
Very good point. Thank you for that.
And me, it's still like you said, the educational piece, but also getting rid of, making aware and getting rid of the misconception of what the profile is for.
Okay.
And letting them know that, hey, it's not more, it's more of a how you rehabilitate from the injury more than riding out on the injury. Because you are able to rehab.
Absolutely, absolutely. What about anyone that's in the room virtually for teams? How do you plan on using this information within your formations or with conversations to either your soldiers or your leaders moving forward?
Okay, so I'll implement like how important rest is for soldiers. Like resting is yeah, like just how important rest is. Sleeping and getting your 8 hours of sleep and everything like that. So you can recover from anything, from any injury that you might have in your body.
Good, good. Sleep is such a critical aspect of our recovery. I'm very glad you brought that up. Thank you, Sean De La Garza. John Coley?
Yeah, what I was gonna say is just like with me and my unit, we have a couple soldiers who are overweight or complained of injuries, past injuries, but uh, sometimes to show them what I've gone through in my 20-some years of being in the military and how you can bounce back from all those endeavors and still maintain what you need to stay in the military.
Very good point. Very good point. All right. Leaders, I'm going to bring this one to a close. I'll close out the recording. As always, I thank you so much for participating in these clinics. It means a lot to me because getting this information to our soldiers is something I'm very passionate about. It doesn't do us any benefit to learn as leaders if we don't use this in order to serve our soldiers. Okay. Now, I want to emphasize the fact that next week we will not have any CTAS clinic. I will actually be at Fort Eustis next week participating in the Army's first H2F Industry Day. I was invited by the Center of Initial Military Training to come, somewhat as a representative of the United States Army Reserve, specifically because of everything we're doing with CTAS, to try and add conversations for Compo 3 and to kind of see what the Army is doing in Compo 1, Compo 2 for H2F. So we'll pick this up again the following week, so not next week. And I fully expect to add as much as I can from that industry day to our CTAS clinics as well as to our folder. So I'll be taking my computer with me and trying to add things. I may take some videos for our overall educational aspect. But again, I appreciate you all being here, and I hope you have a wonderful day. And I will see you in 2 weeks.
Cool.